Welcome back. It is my pleasure to introduce our next speaker, my close colleague and friend, Dr. Paari Murugan, with whom I share the bone and soft tissue service. And just a few words about him. He's an associate professor in our department. He actually started to work here about 1 year, maybe 2 years before I came in 2015, I think.
Yeah, maybe 1 year.
1 year, 2014 then. He's a wonderful teacher. He works very closely with residents, with fellows. He received the multiple teachers awards in 2015, 2018, and 2021. He's also an associate editor for the journal Diagnostic Pathology and a member of the CAP Cancer Committee. He also serves as the program director of the University of Minnesota Surgical Pathology Fellowship and the medical director for CTSI Biorepository and Laboratory Services. So please welcome Dr. Murugan. Thank you.
Thank you very much, Emil. Hello, everyone. Good afternoon. So I'm going to try something a little bit different this time around. So this is the online platform called for the Digital Pathology Association. So I was going to go directly into their platform. This is unique because I don't know if some of you have been exposed to this before, but it lets you integrate PowerPoint presentations along with WSIs. So let's try it out, and please forgive me if there are going to be any technical glitches because I haven't tried it on the big screen before this. Okay, so today let's talk about how we're going to manage risk in soft tissue bone tumors. So I'll be sharing a few examples with you. So soft tissue bone tumors, as most of you know, is kind of a niche specialty in large hospitals that have expert musculoskeletal oncologists. However, if you're in a general practice, you might still occasionally encounter them because general surgeons do take out superficial soft tissue tumors, especially like something like a lipoma. But oftentimes, lesions can be indeterminate, and you might inadvertently come across a soft tissue tumor as such that's not a lipoma. And then the other situation in which you might see soft tissue tumors in a general practice is when organ-specific surgeon like a thoracic surgeon or a GYN surgeon goes in and takes out a lesion, and that actually happens to be a visceral soft tissue or a mesenchymal tumor, right? So when you encounter such a situation, it's obviously critical that you understand the fundamentals, at least the basics of soft tissue bone pathology and what to avoid and what to look out for. And this point, the second point over here, is highly critical because most of the residents and fellows who rotated with me know I keep emphasizing the clinical and imaging information is extraordinarily critical. It's not that it's not important in other specialties, but in particular for soft tissue bone pathology, it's almost like you never sign out one without knowing what the clinical and imaging information is. And then finally, some key advances, not all of them, so we keep getting new molecular advances in soft tissue bone pathology almost every other day, but at least the key basic advances that change diagnostic categories, it's good to be aware of those. So I want to broadly divide what I'm going to talk about into these three main categories and what the pitfalls that can be encountered in these categories. The first one is the red category, where you get malignant tumors with deceptively benign histology. We'll look at a couple of examples there. And then the second category is going to be the other way around. So you get benign tumors with malignant-looking histology. And the final one is going to be soft tissue and bone tumors that mimic non-mesenchymal neoplasm, especially ones that have cytokeratin or epithelial or maybe melanocytic marker reactivity and yet are sarcomas. And then finally, something good to remember is morphologic heterogeneity is notorious in soft tissue bone tumors. So here's my red category case number one. We have a 54-year-old patient who presents with a chronic non-healing wound in the abdominal wall. You can see this over here. So in the abdominal wall musculature, there is an ill-defined lesion that seems to push into the peritoneal cavity and also into the subcutaneous adipose tissue, with perhaps some ulceration of the skin. And you can see because of the nature of this lesion, the patient goes to a general surgeon, and the general surgeon says, apparently they had a pathology report before, which was a biopsy that showed, or probably an excision that showed there was no evidence of malignancy. So the surgeon says it's a non-healing wound secondary to probably surgical excision of a whole hematoma, and then goes ahead to take it out. So this is what we see. So you can see in this whole slide image that there is ulcerated skin over here, and then the dermis has this big old collagenous scar. On this side, let's take a closer look. So you're seeing this ulcer bed with some neutrophils and some granulation tissue, and then you see a myofibroblastic type cellularity going on just underneath that granulation tissue. So it kind of looks okay for granulation tissue. It can be exuberant sometimes, but as you look closer, you're like, maybe the nuclei are a little bit plump, maybe there are some nucleoli, maybe this is something else going on. And then you pull back, and then you see there is some kind of alternating fibrous areas here, myxoid areas here, again fibrous areas, again myxoid areas. But the cellularity decreases, and the nuclear enlargement also comes down, it kind of shrinks. The other thing, when you pull back to lower power, you see is there is this clear line of demarcation between what looks like a dense dermal scar over here and then this particular thing over here, right? So I will show you what we did on this particular case. This stain is MUC4 or MUC4. So you could see, again, MUC4 beautifully highlights the distinction between the lesional tissue over here and the scar. So it's diffusely strongly positive in the more cellular areas underneath the wound and also in the less cellular areas over here. So this can mean only one diagnosis in the setting, and that's going to be a low-grade fibromyxoid sarcoma that was mistaken for a healing wound. So another case here, just as an example. So this is a young patient, again, with a nicely circumscribed deltoid muscle mass. So the differential diagnosis that the radiologist had in this case, and the clinician also, was maybe this is a neural tumor or a myxoma, something like that. And then they give us a needle biopsy. So on this needle biopsy, we can see, again, very similar features from the last case, even lesser cellularity. So it's so bland, you're basically thinking of, okay, is this some kind of cellular area from the periphery of a myxoma? Is this some kind of fibroma, maybe a neurofibroma? Or maybe they just missed a lesion and went tangentially through into the capsule. So all these are going through your mind, but again, now you know what this lesion is going to be. When we do the MUC4, it's strongly and diffusely positive. So this is another case of low-grade fibromyxoid sarcoma. So I just wanted to go back a little bit to the previous slide and see if I can compare it with another case I have on file over here. So let's try this. So on the left here, this is the low-grade fibromyxoid sarcoma I just showed you. Let's zoom in and keep it there. And then on the right side, this is a lesion that's been excised from a knee joint. This is a patient who had hardware failure, and then the hardware material leaks out and then forms a fibrotic scar reaction, right? And here you can see evidence of that foreign body type giant cell reaction. So if you polarize this, you will get all these material, which is basically the polyethylene that's polarizing. And then adjoining it, we also see more obvious evidence of giant cell reaction. You keep going, all this is a scar, 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 everything is a scar, right? And then you get a big old scar here too. It's just that this scar also has some myxoid areas. So if you zoom in on any of the areas in this particular scar, you can see that there's hardly any difference between our low-grade fibromyxoid sarcoma and what is obviously a scar. So this is a huge pitfall, right? So I will show you a little bit more of this later on, but right now I want to show you a couple of other things that low-grade fibromyxoid sarcoma can do, right? Same patient, we get this abdominal mass which was resected with this area which we now know is low-grade fibromyxoid sarcoma, but I want to show you the other section over here. So we get these low cellularity areas that we saw in the biopsy and also on the excision of this patient, but as you keep scrolling, you come across areas that are much more cellular. So low-grade fibromyxoid sarcomas can undergo dedifferentiation, right? So that's something that we got to watch out for, and the cellularity can keep increasing, and it can even become pleomorphic at some point. And then the other feature I wanted to quickly point out here are these little pretty florets, right? So these are called hyalinizing giant collagen rosettes. So this tumor was previously called as spindle cell tumor with hyalinizing collagen rosettes. We don't use that name now because we know it's all part of low-grade fibromyxoid sarcoma. So the other sort of morphological variation with a slight genomic change is this lesion called as a sclerosing epithelioid fibrosarcoma, right? So you zoom into this, you see some areas that are similar to what we saw previously, but there's a lot of sclerosis over here. And then I want to show you some specific areas in this particular lesion. Let's go over here and zoom in. So you can see that the nuclei, unlike the LGFMS that we saw earlier, are very rounded, right? They're small, but they're rounded. But look at the fibrotic stroma over here, right? This is almost like the what is called as an Indian filing pattern in lobular carcinoma of the breast, or plasmacytoid urothelial carcinoma, or diffuse carcinoma of the stomach. And this, if you do EMA, this is going to be strongly positive. So this is another huge pitfall in these tumors. One has to recognize that this pattern is possible in low-grade fibromyxoid sarcomas. Okay, so in conclusion for this case, so you have to remember, in order to avoid making a misdiagnosis, that these can be deceptively bland spindle cell lesions. So we have a extremely low threshold for doing the MUC4 immunohistochemical stain in our practice. Any lesion from especially a younger patient, deeper soft tissue mass, so do not hesitate to use MUC4 liberally, because that mistake is not worth it, because these tumors can metastasize, and they can metastasize very late. So we tell our oncologists that these patients have to be literally followed up for a lifetime, okay? So another case in the red category over here. So this time we have a younger patient with a posterior knee mass. And you can see this little polypoid bony protrusion coming off of the backside of the femur in this patient. And apparently a biopsy was done earlier. And the radiologist, on reviewing this X-ray, says the findings remain in keeping with the histological diagnosis of an osteochondroma, right? So this looks appropriate at this point. I want to show you what we saw in the biopsy. So this is a biopsy. So if you look at this from a scanner perspective, you will see that there is sort of a cartilaginous cap over here. And then you could see sort of a periosteum or perichondrium on top. And then from the cartilaginous cap, there is a bony outgrowth, which is essentially enchondral ossification, which is the same as what you will see in an osteochondroma. So nothing seems wrong with the diagnosis of osteochondroma on what we see in this biopsy, and it seems to correlate with the radiology as well. But when you look closer at the cartilage, the chondrocytes here, there is something wrong, right? Because in an osteochondroma, if you look at the cartilage cap, you will see these lobules or clusters of chondrocytes. But it's all so irregular over here. And you can also notice that some of these chondrocyte nuclei also are starting to look atypical, very dark, right? And then you pull back and look at this so-called perichondrium. So what is actually going on here? So it's way too thick, right? And it is cellular. And if you zoom in, you will see the same atypical, very dark-looking cells, okay? So what about the bone then? So is everything okay with the bone? It seems so from low power, but There is some fibrotic tissue in between the bony trabeculae. So typically in osteochondromas, you see marrow. Instead here, you see fibrotic tissue. Maybe that's just reactive change, right? So that's possible, but something is certainly wrong with the cartilage and the fibrous tissue. So what we did in this case is this stain. This is MDM2, right? So on the MDM2, you can clearly see that this is diffuse strong nuclear reactivity in that fibrous stroma surrounding the cartilaginous cap. And not only that, even in the cartilaginous cap, I know it's folded a little bit, but you can still see all the chondrocytic nuclei that are strongly and diffusely positive, right? And not only that, you go in between the bony trabeculae and you see the fibrotic stroma where you can see the nuclei are strongly diffusely positive. So this is a case of parosteal osteosarcoma. It is not an osteochondroma, right? So I will show you an example from another patient of a related tumor, which is basically a low-grade osteosarcoma. Parosteal osteosarcoma has the same genomic and morphologic features as a central low-grade osteosarcoma. So this is a central low-grade osteosarcoma. Here, if you notice, you can see there is a bony outgrowth coming out, and you can see the same type of cartilaginous material, like a cartilaginous cap, and irregular formation without lobulations here, right? And then you go into the center of this lesion, we'll see all the marrow is gone. Obviously, the bony proliferation is highly abnormal. A couple of points that you want to notice here is that these long parallel trabeculae of well-formed bone, right? Long parallel trabeculae. And even here, you can see the long parallel trabeculae, right? And then you go in between these trabeculae, you see that it's very bland. It's a very bland fibrotic or fibroblastic proliferation. If you are just sticking to high power, it's going to be really hard to make a diagnosis of malignancy in this case, right? Another feature that I want to show is if you go to the area that looks like this, for example, right? So I focus in here and I show you this, and if I ask you, like, what do you think this most probably is going to represent? And most of you are going to say fibrous dysplasia, right? And you would be absolutely correct, just not in this case, right? So, yeah, so I just wanted to compare a case of fibrous dysplasia with this one. Let's see how this works out. So let's zoom in right here, somewhere around, right? And we'll stop here, and then anywhere in the fibrous dysplasia, you could just go in and just compare. So the bony trabeculae look very similar. In fact, the fibrous dysplasia looks more cellular and more hyperchromatic than our malignancy. So this is a huge pitfall, and one has to be aware of that. So let me exit out of here, and then I want to show you another feature that's also another big pitfall in cases like this. So focus on this area here, right? So I'm going to pull up another case for comparison. This time it's going to be this one. So let's zoom in here. Okay, so you see these irregular trabeculae of bone, some of them broader, and then this fibrotic material here. And then you go into this case of myositis ossificans, just zoom in anywhere. And so you can see how hard it is on a biopsy or a curettage material to tell the difference between these two unless you have full clinical information. Sometimes, even if you have full clinical information, myositis ossificans many times is just a lesion in the muscle, which is very close to the bone, which is what parosteal osteosarcoma does, right? So it's going to be very similar. However, there is one escape route in this particular situation, because if you pull back, you will see in a myositis ossificans, as most of you know, there's going to be a distinct zonation phenomenon, right? So you can see that phenomenon over here. So you see more mature bone on the periphery, and then less mature bone in the middle of the lesion, and then just a fibroblastic proliferation in the center. So if you pull back on the low-grade osteosarcoma, it's going to be irregular bone everywhere. There is no zonation at all, right? So in a larger specimen, this is a very, very useful clue to make the distinction between these two lesions. All right. So, and then the other thing about low-grade osteosarcomas is that they can metastasize, right? And even when they are in the low-grade state, they can metastasize. So I want to show you an example of that. So here, just so you will believe me, this is actually bronchial epithelium, right? So this is in the lung, and we can see similar type of very, very low-grade, bland-appearing fibroblastic proliferation and these bony strands. So this is metastatic low-grade osteosarcoma in its low-grade state. However, most of these cases do dedifferentiate before they metastasize. Even in this case, you could see there is higher cellularity in this particular area, so it's on its way to becoming dedifferentiated. So in summary, low-grade osteosarcoma is obviously a deceptively bland spindle cell tumor with well-formed bony trabeculae, unlike your traditional high-grade osteosarcoma, and the cartilage cap can also give you really good clues. So the good news is MDM2, really good immunohistochemical stain. If you know how to use it appropriately, it will be positive in greater than 85–90% of cases. If not, if you still have a suspicion, you can always do MDM2 FISH. Right? And these cases often recur locally, but the most important thing is they can metastasize. All right, so we are at 3:52, so maybe I'll skip the next one. And go on to our first green case, right? So this will be a 24-year-old pregnant patient, so a young patient with a recently enlarging thigh mass, which you can see over here. So this is about like a small 3-centimeter lesion, which appears well circumscribed, but it is situated sort of in the deeper soft tissue. So that skeletal muscle is in the deeper soft tissue. And then on further history, we see that the surgeon has recommended she needs to have prompt orthopedic oncologic evaluation. And the additional history we knew about this patient was during her previous pregnancy, she had the same lesion, but after her pregnancy ended, it reduced in size. So here is a needle biopsy from this particular mass. And as you can see, most of it is fibrotic, but there are also some cellular areas, right? So let's zoom in on the cellular areas. Even before I go any further, you would have noticed that this lesion is highly bizarre, highly pleomorphic cells, right? So much variation, nuclear size and shape, and you got a lot of hyperchromasia, right? So, and I think my colleague also marked mitosis somewhere over here, so perhaps this one is even like a atypical looking mitosis, right? But then we also noticed some other things. So the cytoplasm is very foamy, almost histiocytoid cytoplasm. And in addition to that, the cells reveal their histiocytic nature by the fact that they do have this hemosiderin pigment inside the cytoplasm, almost like lysosomal digestion of hemosiderin pigment. So, and it was positive for histiocytic marker, also for factor 13A. Now, factor 13A is not entirely specific, but in this situation, it gives us a good clue towards the diagnosis. In addition, we see some collagen trapping here as well. So this is a great example of a benign fibrous histiocytoma with monster cells, so-called monster cells, especially if you put it in a context of a young patient whose lesion enlarged during pregnancy. Perhaps there is some hormonal stimulation as well. So this is a completely benign lesion that is mimicking a high-grade pleomorphic sarcoma. So I want to show you a few more examples of benign lesions that can do this. These are some of the lesions that most of you might encounter in routine practice. So here's a needle biopsy from a deeply located soft tissue lesion that was indeterminate by radiological examination. So if we zoom in, we will see it's basically a spindle cell lesion with some myxoid areas and also some pink areas. And but what meets the eye over here is the fact that you have all these really large nuclei, right? Large nuclei that are irregular, that have irregular nuclear borders, and also very hyperchromatic. And it's not just focally seen. Throughout the lesion, you go anywhere, so you're going to see these nuclei, right? But most of you know the answer for this one. I'm going to reveal it right here. So when you do this particular immunostain, you know exactly what we are talking about, right? So it's a diffusely strongly positive S100. This is nothing but a schwannoma with degenerative or ancient change. And I want to show you another example over here, which is even worse than the biopsy we just saw. So as you can see from this low magnification, it's a nicely circumscribed, very, very small lesion, like smaller than a marble probably. But if you look closer, you will see that there is so much atypia here, like significantly enlarged nuclei, hyperchromasia, again, irregular nuclear borders. But in this particular case, a helpful clue is that, again, it's very small, of course, and you don't have any mitotic activity at all. So this is often a helpful clue in schwannomas with ancient or degenerative change. And then other soft tissue lesions can also do this. This is an example that many of our gynecological pathologists would be very, very familiar with. But this is a soft tissue lesion, not exactly a leiomyoma. We call it angiomyoma. So you can see all these blood vessels embedded in this lesion and the smooth muscle cells proliferating outside of it, right? So I want to take you to this particular focus. If you zoom in, you will see that there are these highly pleomorphic nuclei that, again, gynecological pathologists will say, oh, this is just symplastic change. Yeah, this is a symplastic change in a angiomyoma, just like what you see in a leiomyoma in the uterus. So finally, I want to end this topic with this particular case that we got recently in our practice. So this is a lesion that is fatty. It has some myxoid change, and it also has this ropey collagen, spindle cells. So all features look good for spindle cell lipoma, right? But then if you go into this area over here, again, you start seeing our usual culprits, the pleomorphic darker cells with larger nuclei. And in this case, though, if you zoom in, you will see it's not a single nucleus. There are multiple nuclei over here, arranged in a wreath-like fashion all around the cytoplasm. So this would be your two-tone cell, and that would make it a diagnosis of a pleomorphic lipoma. So spindle cell pleomorphic lipoma combination can occur, and that can sometimes trip you up if you're not aware of that entity, right? So finally, I want to end with the case in comparison. So this is a patient with an older patient with history of Lynch syndrome. So obviously, they have propensity for developing malignancies. And this time, we have this huge mass, a rapidly growing gluteal mass, right? So let me compare this case with the one we had previously, our pregnant patient with the BFH. So I want to zoom in to anywhere on this high-grade pleomorphic sarcoma, right? And you see highly atypical mitotic figure, and then highly pleomorphic cells. But you also see areas that have somewhat of a histiocytoid cytoplasm, like we saw in the other case, right? That foamy cytoplasm. So if you go zoom in to this lesion, you know what you're going to see. You're going to see something that is very, very similar to this high-grade pleomorphic sarcoma, another huge pitfall. So the clinical context is so key in diagnosing these type of lesions correctly. So in summary, benign atypia in soft tissue neoplasms can morphologically mimic malignancies particularly if one is not aware of these lesions. And the most common examples are the ones we saw, master cells in BFH, so-called ancient changes in schwannoma, and symplastic changes in smooth muscle tumors. And overall, most of these lesions have low mitotic activity and no atypical mitosis, except for in rare cases of BFH, you can have some atypical mitosis, but it still behaves in an indolent manner. And usually you don't see necrosis. So imaging and clinical features are really helpful in this type of setting. Okay, so this case is another green case, so you know what it's going to be. But let's look at the history. This is an older patient this time, so 78-year-old patient with a deeper mass. So there's a deep thigh mass over here, and it's located in the skeletal muscle, and it doesn't have circumscribed borders, right? So it's infiltrative all over. So the first thing you think of, older patient, infiltrative deep mass, is going to be sarcoma. And that's exactly what happened. So it was biopsied, and it was actually called an undifferentiated pleomorphic sarcoma. And then the surgeon sees this and says, I reviewed the MRI scan as well. I looked at the biopsy and says this, certainly the findings are consistent with the diagnosis, right? And they are discussing chemotherapy and radiation therapy. So let's see what this biopsy actually showed. right? So here we see a very cellular lesion, and all the pink blobs, are the skeletal muscle bundles. So the skeletal muscle seems to be infiltrated quite diffusely by this highly cellular lesion. So we take a closer look at what's happening in the infiltrative lesion, and we immediately notice that, yeah, they were absolutely right in calling this undifferentiated pleomorphic sarcoma, because it looks so ugly, there is so much pleomorphism, and we also, if you look, like you could see mitotic figures that some might argue is even atypical looking, and then you see these huge cells that have an eccentric nucleus and abundant purple cytoplasm, almost like a ganglion cell-like appearance, right? So, but there's something that is weird about this case. So if you pull back, you will see that the soft tissue proliferation seems to be respecting the muscle bundles, right? So it's not really like playing apart and then destroying everything. It's kind of softly insinuating in between the muscle bundles. So that's kind of a clue. So SMA was done in this case, and it just proves to you that it's diffusely strongly positive. It just proves to you that this is a myofibroblastic proliferation. So this happens to be a case of proliferative myositis that mimics a sarcoma. So then we made this diagnosis, and then the surgeon comes back in 4 weeks and tells us that everything is improved. He's 95% okay now, and he didn't even want to do a follow-up MRI because there was no lesion to be found. So this was completely resolved in a matter of 1 month. No chemo radiation. So this is another example of proliferative myositis that was inadvertently excised before the biopsy. So you can see here that typical checkerboard pattern that we talk about in myositis, proliferative myositis. So you can see muscle bundles and then this type of myofibroblastic proliferation. This is a macro checkerboard, and then if you go closer, you will see what we saw in our biopsy, like the micro checkerboard where you see these myofibroblastic proliferation going in between individual muscle bundles. And similar to that case, so if you look at this, you will see these ganglion-like cells, right? So that's a clue for proliferative myositis. So then now we move on to another related lesion. This is a notorious lesion that's mistaken for sarcomas. It's like the poster child for a pseudosarcomatous proliferation. And most of you know what I'm talking about here. It's nodular fasciitis, right? So nodular fasciitis can sometimes it most of the times goes up from the fascia into the subcutaneous tissue, but sometimes it can go into the skeletal muscle too. So in this case, we can see this lesion which is arising from the fascia that is just above the skeletal muscle, and it's so cellular, right? Cellular with myxoid change, and sometimes you can find the plump nuclei, and you can also find a large amount of mitotic figures over here. So these can, without proper clinical history, this can easily be misdiagnosed as at least an intermediate grade sarcoma. So watch out for nodular fasciitis. So here is a case in comparison though. So this time we have an older patient, nearly 80 years old, and the mass is subcutaneous. So it's not a deep mass, it is subcutaneous, but it's quite large. It's nearly 7 centimeters, and it also has this MRI signal that extends beyond the border of the mass, seemingly infiltrating into the septations around the adipose tissue over here. So if you look at this mass from a low power, this and the nodular fasciitis look pretty much similar, right? But when you go higher, you will see that there are these larger caliber blood vessels. So if you do the CD34 or CD31, this will pop out, but you can see these are larger caliber blood vessels, and they have this very hyperchromatic nuclei. So again, I'm gonna do my same trick. I'm gonna pull this up and then compare it with your nodular fasciitis. Most of you know what we're going to see here. So this is our case of myxofibrous sarcoma, which we just saw in this older patient with a large subcutaneous mass. So myxofibrous sarcoma can be very tricky because unlike most soft tissue sarcomas, it occurs in the subcutaneous tissue and not in the deep muscle. So I zoom in on my myxofibrosarcoma, and then you can like pick any area in this nodular fasciitis, and then just zoom in, right? So you could see how these look very similar, right? So without the proper clinical context, it can be almost impossible to distinguish between these two lesions. But when you do look carefully, you will see the nuclei are very hyperchromatic in the MFS, unlike in the nodular fasciitis. So I want to finish with a couple more pseudosarcomatous proliferations. So this is a patient who unfortunately had a testicular torsion and couldn't come to the hospital for a few days. And so when they resected his testicle, they found a large soft tissue-like mass around the torsed testicle, which was completely non-viable. And from a low power, you can see here that there is a huge hematoma, or which is trying to resolve. And on the borders of the hematoma, you can see this spindle cell proliferation. So this, in fact, is an exuberant myofibroblastic or a wound healing type of proliferation that you find adjacent to areas of a hematoma. But when I zoom in, you will see why this can be so difficult, right? So when I first look at this, I'm like, it's a spindle cell angiosarcoma. And when you do ERG, maybe inadvertently, you will see that ERG is positive all over because you have so many blood vessels in here. And anywhere you look, you can easily identify mitotic figures in this particular case. So this pitfall is huge, but when you pull back, you know that whole picture, the testicular torsion, and you have this huge hematoma and this proliferation. So that's going to be a myofibroblastic proliferation. Another pitfall in this, if we don't have enough pitfalls right now, is the fact that these can be positive for keratin, right? So you do a pan-keratin, like an Oscar or A1, A3, this is going to be, some cases can be strongly diffusely positive because myofibroblasts have the tendency to exhibit low molecular weight cytokeratin positivity, right? So if you are worried about sarcomatoid carcinoma, then you try some other markers, other keratins which don't have the low molecular weight cytokeratins, or you just add an SMA and you will see that this is all positive for SMA. So pseudosarcomatous proliferation or big pitfall, they can be highly cellular, mitotically active. Usually they have a short clinical history, unlike sarcomas. And some of them have genomic abnormalities, like nodular fasciitis with USP6 rearrangements, but most of them don't. And as I said, low molecular weight cytokeratin can be positive, so you need to watch out for that. All right. So now I want to move on to our next category of tumors, that is the soft tissue neoplasms or sarcomas that mimic non-mesenchymal tumors, right? So I want to show a couple of cases, maybe a third case if time permits. So here we have a 53-year-old patient who had a gradually enlarging right wrist mass. So you can see the mass both in the axial and the coronal here. So there's a small little mass over here just underneath the skin, looks really nondescript. So the surgeon sees it and says, oh, it's fibromatosis, giant cell tumor, fibroma, whatever, it's benign. So I'm going to take it out, right? But our surgeons are very intelligent. They know much better than to just take it out. So they did a biopsy. So here you can see mostly it's a fibrous tumor, and then here's the cellular area. So in the cellular area, we see there's some sort of organization here. So there seems to be a palisading of these nuclei. And then within the center of the palisade, so you see there is sort of a degenerative type of, maybe a necrobiotic type of, maybe a granuloma-like formation over here with palisading cells. So when you look closer at these cells, there's not really much going on. It looks like maybe inflammatory cells, or maybe histiocytes around a granuloma, so doesn't look like much, right? So, but our residents know what I'm talking about here. This is EMA, and cytokeratin is going to show you the same pattern, right? So this is the necrobiotic area, and then all the tumor cells are diffusely strongly positive for EMA. And this is INI1, and you can see all the tumor cells have, the nuclei have lost INI1. So this is a case of epithelioid sarcoma that mimics granulomas, and it can be very small and nondescript as well. So I want to compare this with a case of a rheumatoid nodule, right? So rheumatoid nodule is the closest lesion where you get a granuloma with necrobiosis in the center. So we can just zoom in anywhere here. You can see that there is a similar type of necrobiosis going on in the center, and it's surrounded by a vague palisading of these plump cells, which are basically histiocytes. In this case, it may be slightly difficult to identify this as not as an epithelioid sarcoma because you do have this chronic inflammatory infiltrate in the background, as you might see in a rheumatoid nodule. But let me show you one more case here. So this is a case of granuloma annulare. Right? Again, in a young patient, epithelioid sarcomas do occur in young patients. So in the granuloma annulare, you don't see too much of inflammation, but you see a similar type of epithelioid-looking cells and a central necrobiosis. So I'm going to do my comparison here. I'm going to pick my case of epithelioid sarcoma and put them side by side. So let's zoom in on the granuloma annulare. So that's where we are at, right? So let's zoom in anywhere on the epithelioid sarcoma. So like similar magnification, even higher here. So you could say that the granuloma annulare probably has more atypia than the epithelioid sarcoma, right? So this is a huge pitfall, and we need to recognize. And like the MUC4 for low-grade fibromyxoid sarcoma, this is a very easy way to make the diagnosis. Just liberally use keratin whenever you see a lesion like this. No harm, no foul. You just make sure the keratin is negative before you call anything as granuloma annulare or a rheumatoid nodule. All right, so epithelioid sarcoma, as most of you know, can have this histiocytic look and can have central degeneration and mostly young patient distal extremity. Any lesion, any nodule in the hand or feet of young patients, I don't even look at the slide. You could just order cytokeratin just to make sure, right? So it's that bad because it's such an aggressive tumor that can have local and distal metastasis. So at this point, I also want to quickly mention some CK-positive sarcomas. Epithelioid angiosarcoma is a big culprit. Synovial sarcomas, obviously you know. Alveolar rhabdomyosarcomas can sometimes be positive for keratin. Epithelioid MPNSTs, and also desmoplastic small round cell tumor can be keratin positive, right? So this case, I want to quickly go through this. We have a couple of minutes here. 40-year-old patient with a knee mass increasing in size for the past year. So here you can see the mass. And then the surgeons are like, oh, we don't know what this is. It could be benign, malignant, whatever, right? And then you can see here there is a patella, and then this is actually the patellar tendon. And the lesion is sitting right bang in the middle of the patellar tendon. So you look at the biopsy on this one, and you zoom in, you will see that this is a nest of epithelioid cells, several nests and some cords of epithelioid cells, right? And then you also have some of the cells having more prominent nucleoli. And then a peculiar feature is that you find these giant cells in this particular lesion. And I want to show a similar case, or before that, we have some immunostains. So this is S100, strongly diffusely positive. This is HMB45, strongly diffusely positive. And Melanie also showed the same thing. So you know what this is, right? So this is a melanoma? No, it's not going to be a melanoma because I'm not showing melanomas in this session. So it is a clear cell sarcoma, of course. So here's another case where clear cell sarcomas can actually form melanin pigment, right? So look at that. So they do produce true melanosomes. That's why they are positive for all those melanocytic markers. But the treatment is going to be totally different. The clinical behavior is going to be totally different for clear cell sarcomas. So we need to get the diagnosis right. So what are we going to do when we get all melanocytic markers positive? So how are we going to tell the difference, right? So one is melanomas typically don't have these multinucleated giant cells. So that's kind of a clue. And then BRAF is very unusual in clear cell sarcoma. There are some case reports that say BRAF can be positive in bona fide clear cell sarcomas, but in most situations, it can be useful if it's diffusely strongly positive, especially if the lesion has junctional activity and is associated with the skin, right? But then the confirmatory way to make sure it's a clear cell sarcoma is to do EWSR1, which is going to be positive, right? And you just also need to know the other melanocytic marker positive sarcoma is going to be a PCOMA. So I'm going to skip this case in the interest of time, but I do want to show you one last case in conclusion, this case X. Right? So here we have a 33-year-old patient with an index finger bone lesion and history of a cat bite, right? So very clear history here. And then the radiologists look at this and say, oh yeah, we see a lesion in the bone, the phalanx over here. It looks like osteomyelitis. There is some overlying cellulitis. So here's the kicker. You can see here, there was a diagnosis that we got on this case from an outside institution which said epithelioid neoplasm with cytologic atypia, likely representing carcinoma, adnexal carcinoma, intraosseous squamous cell carcinoma. So the surgeon was pretty much blown away by this diagnosis, and they were like, okay, an expert soft tissue bone pathologist also saw this outside, and they concur with the above interpretation. So let's look at this slide and see what they actually saw. So I want to start here, down here. You see this cartilage, and then you see this bone. So basically, there's an exudate associated with this cartilage, acute inflammation, no problem. It's acute osteomyelitis. Same picture here, broken bone, inflammation, acute osteomyelitis. So no problems at all. Then, oops. It's a very unfortunate moment for it to go off. Well, digital pathology, right? That's why you need a scope. Okay, here we go. So, yeah, so we discussed that there is clearly osteomyelitis, but we want to look at the elephant in the room, right? So this tissue. So what's going on here? So I show this tissue to any of our residents who are on the GU service and ask them what this is, and they're going to be, non-invasive papillary urothelial carcinoma, probably low grade, and they're like, oh, there are umbrella cells here, there's a papillary formation here. The additional thing I want to point out here is that, you see this? This is cautery effect, right? So cautery effect in the soft tissue surrounding this, and I call up my orthopedic surgeons and ask them, when you do a bone curettage, do you ever use the cautery? And they're like, no, never. So then why is this piece of tissue having cautery effect and the osteomyelitis is just clean? So because this is a floater, right? So there's no correlation with the imaging here. There's no correlation with the clinical history, and the tissue was not present on any additional sections, and you make a rare esoteric diagnosis of intraosseous squamous cell carcinoma. That's just not going to happen, right? So most of these cases with a floater are resolved by available info. You clearly know that's a floater. In some select cases, you may need DNA testing. And in this particular patient, you'll see that in a four-month follow-up, she's very pleased. We took away the diagnosis of carcinoma. Nothing more was done, and she regained full motion of her finger. So take-home lessons here are very obvious lessons. So we need to have some knowledge of the benign appearing aggressive entities in soft tissue bone pathology, and also the pseudosarcomatous lesion. And we need to be aware of soft tissue bone tumors that can have non-mesenchymal histology as well as non-mesenchymal IHC, right? And always, always, always correlate with imaging and clinical information, especially for a resident. Don't ever sign out soft tissue bone cases without this information. And then, and lastly, when in doubt, please don't hesitate to ask for help. Thank you.